Good morning to all of you. Today we shall discuss about a few points on the fetal development and fetal physiology. Now, of late, the understanding of the fetal development has become important because once the conception has taken place with the advanced investigation facilities and the advanced technology, we are able to monitor the progress and the development of a fetus on a monthly basis. So right from the time the conception taken place and the inception and the implantation has taken place, with the help of an ultrasound scan, we can study or monitor the progress of the fetal development on a trimester basis. So first trimester, first 3 months, second trimester, second 3 months, the third trimester, the last 3 months of the pregnancy, we can monitor whether the size of the fetus is growing, the development of the organogenesis, externally gross organ development, whether it is taking place normally or not. And with latest techniques like amniocentesis or studying the taking out the fluid from the amniotic sac, we can also study whether there is any abnormalities or not. So it becomes a little important that we understand what is the rate of the development of the fetus taking place on a monthly basis. Now, once conception has taken place, implantation has taken place, let us study the fetal size. Now, post fertilization, if we see 2 to 3 weeks after fertilization, the fetus is little microscopic in size. Now, by the time it is 12 weeks into gestation, the length of the fetus is somewhere around 10 centimeters. By the time we are into 20 weeks of gestation, the size of the fetus or the length of the fetus is somewhere around 25 centimeters. But at term, at 40 weeks, it is somewhere around 53 centimeters in length or 21 inches in length. Now, these parameters are important because in case there is a non-development or a slow development of the fetus, when you do a scan, say let's around ultrasound scan at around 12 weeks, you will find that the size of the length of the fetus is not 10 centimeters. There you can understand that somewhere the growth of the fetus is slowing down. So there is a growth retardation taking place. Similarly, at 12 weeks, you may find that the length of the fetus is 10 centimeters, but when you do another scan at the end of 20 weeks, you may find it is growing at around 20, the length is around 25 centimeters, or just around term it may be less than 53 centimeters. So any growth of the fetus which does not correspond to the standard values, that means that there is a slowing down in growth and the development of the fetus is not taking place on expected lines, and this means that there is somewhere intrauterine growth retardation. Whatever may be the cause of the growth retardation, we have to analyze that. But first, to diagnose that there is a slowing down of the growth, this ultrasound scan helps us, and the knowledge of the length and the weight helps us in assessing about the growth retardation. Similarly, the weight at around 5.5 months, around 5 months of conception, the weight of the fetus should be somewhere around 1 pound. By the time it is 7 months, it is somewhere around 3 pounds. At 8 months, it is around 4.5 pounds, and at term, it should be somewhere around 7 pounds. Remember, 1 pound is somewhere roughly on a rough scale basis, it is half a kg. So let us say at 5 months of conception, that is into the second trimester, 5th month of pregnancy, the weight should be somewhere around 0.5 kgs. By the 7 months, it should be somewhere around 1.5 kg, and 8 months, that is nearing the 8 month, it's nearing term, I mean to say, it is somewhere around 2.5 kgs, and at term, when the baby is born after 36 to 38 weeks, the weight should be somewhere around 3.5 kgs. The weight may be less developed, again indicating that if the weight does not correspond to the standard weights, that means that there is inadequate nutrition going to the child, inadequate gross organogenesis taking place, hence the child is not, fetus is not putting on weight. Again an indication of the intrauterine growth retardation. But if you see here, you will find that at term, the 7 months, let us say when the 7 months of conception, the weight is somewhere around 1.5 kgs. So by term, there is a sudden gain in weight. In other words, if you analyze this chart, you will find that the maximum weight gain of the fetus takes place in the last 2 months, last 4 to 6 weeks of pregnancy. There is a sudden spurt from 1.5 kg, the child has to put on to somewhere around 3.5 kgs. So the maximum gain of weight by the fetus occurs in the last trimester, and in the last trimester also in the last 1.5 weeks, 4 to 6 weeks, the weight gain takes place. Typically, this is the weight of the fetus. Typically, during the whole duration of pregnancy, that is 36 to 38 weeks of pregnancy, a mother will gain somewhere around 11 kgs of weight. So from the day before the onset of pregnancy until the term period, if you observe, the weight gain should not be more than 11 kgs, 11 to 12 kgs. And this gain of weight is typically, out of which 11 kgs, you will find 3 to 3.5 kgs will be the weight contributed by the fetus. The rest of the 8-9 kgs is because of the increase in the blood volume and because of the weight of the placenta. Now, the other organ development, if you see, the other important factor is after conception has taken place, implantation has taken place, the cardiac activity has to begin. Now, the cardiac activity begins at around 4 weeks of gestation, and the average heart rate is somewhere around 65 per minute. By the time it is term pregnancy, the heart rate increases to around 140 beats per minute. Now, this is another parameter which helps in assessing the fetal well-being, and the marking and measuring the heart rate will help to know whether the child is in distress or not. Now, after conception, by 4 weeks, if you do a ultrasound scan, or a 6 weeks, you should be able to see the cardiac activity. The sonologist will be able to record the beatings of the heart. So that happens at 4 to 6 weeks of gestation. In the initial trimesters of pregnancy, the heart rate is somewhere around 65 beats per minute. But as the size of the fetus increases, the organogenesis takes place. The heart rate is somewhere around 140 beats per minute. Now, monitoring the fetal heart rate is one of the important parameters to know that the fetus is not in distress. Now, if there is a distress in a sense, it means that if the oxygen supply to the fetus is reduced, the heart rate will increase. So, instead of 140 beats per minute, it may increase to around 150, 160 per minute. So, at term gestation, when the mother is in labor, you keep counting the fetal heart rate, and if you feel that the heart rate is beyond 150 per minute, that means that the fetus is in distress. You have to initially or hurry up the stages of labor and deliver the baby out immediately. It can be on the other hand also, if the fetal distress has already happened and there is no improvement taking place, the heart begins to slow down and somewhere it comes down to around 110 or 100 per minute. That means that there is a fetal slowing down taking place, and that fetal slowing down also indicates that the fetus is in distress, especially during the term when the mother is in labor. It means that you have to urgently deliver the baby, bring the fetus out. So either way, it is very important that you know what is the heart rate, and in addition to this, you will also find that there are certain nowadays fetal movements. The mother is trained to count the number of times the child is kicking. The mother can feel the fetal movements, and the mother is asked to count the fetal movements per day. So if the fetal movements is little less, it indicates that there is a fetal distress and the mother needs to go and see the obstetrician. So in this way, the heart rate helps us in helping assessing the fetal distress, whether there is a fetal distress or not. Secondly, the cardiac output is also constant. Somewhere it is around 500 ml per minute. This somewhere the last line is wrong. Now regarding the development, fetal development, you will find that the RBCs begin to be produced. You know that if you remember the earlier classes, we said that the fetal development starts from the first trimester itself, and in the first trimester it happens in the yolk sac, in the second trimester it is in the yolk sac, and it also occurs in the mesenchymal cells and the liver, and ultimately it is the liver, spleen and the lymphoid tissue which takes part in the development of the RBCs. So the fetal RBCs, the fetus starts producing the RBCs on its own. In the initial, that is the first trimester, in the third week, you will find that the RBCs are having a nucleus, and this nucleated RBCs are the primitive RBCs nonetheless, but they help in transfer of oxygen, and it is formed in the yolk sac and the mesothelium of the placenta. By the time it is 4 weeks, the nucleated RBCs are gone, and to 4 weeks of gestation, you will find that there are the formation of the non-nucleated RBCs, and this nucleus, these RBCs are produced by the fetal mesenchymal cells and the endothelial cells. By 6 weeks of intrauterine life, the liver starts forming the blood cells. By 12 weeks, that is somewhere around 3rd month, it is in addition to the liver, you will also find that the spleen and the lymphoid tissue begin producing the RBCs. In addition to this, you will also find that the bone marrow also starts producing. It is the bone marrow of all the bones which start producing the RBCs. The red and the white blood cells and other cell structures lose ability to form blood cells. As the bone marrow begins to take over the functioning of the production of the RBC, you will find that the other organs which were initially forming the RBCs now stop producing these RBCs, and it is solely the function of the liver and the bone marrow of all the bones which produces the RBCs. Now once the RBCs are produced, where does it goes? Where does it takes the oxygen from? Basically, the fetal lungs are not well developed. They are collapsed lungs. They are filled with water or they are filled with amniotic fluid. So the oxygen supply to the fetus is through the placental membrane, and it is through the diffusion. And it is a simple diffusion which is happening across the placental membrane, and this diffusion also follows the principles of physics which is applicable in an adult across the pulmonary membrane. So oxygen diffuses from a higher concentration area to a lower concentration area. Here across the placenta, it is the simple diffusion will takes place from the sinuses through the villus membrane down the pressure gradient. If you see the oxygen saturation or the pressure of the oxygen in the maternal blood somewhere around 100 mmHg, whereas in the villus, in the villi, it is somewhere around 50 mmHg, whereas in the fetal membrane, in the fetal blood, the RBCs which are in the fetus will have oxygen, and their saturation of the pressure there will be somewhere around 30 mmHg. So across the placental membrane, you will find that there is a gradient which is being built up from the maternal side to the fetal side across the villus, where from 100 to 50, and once this diffusion takes place from 50 to 30. So in this way, oxygen is transported into the fetal cells through a process of diffusion because of the concentration gradient, difference in the concentration gradient. Now there are at different places in the fetal circulation, you will find that there is a shunt existing. Now what does this shunt means? Now in the fetal circulation, there are 4 shunts. Basically this has been taught to you in the anatomy, I am just going through it roughly. Now this shunt means that the blood is bypassing certain organs and going into the organs above it, or going into the structure above it. So this bypass is known as the shunt, and there are 4 shunts. One of the basic shunt, and the most important shunt here, is the placenta, where you will find that the blood is passing through the placenta, bypassing the other things. So there is one important shunt which is the placenta, and it is the main source of shunt and fetal circulation. The other is the ductus venosus. What is ductus venosus? In ductus venosus, the circulation is bypassing the liver. The hepatic circulation is literally non-functional. So there the blood which is draining from the lower half of the body, draining into the inferior vena cava, that is from the umbilical vein, it goes into the inferior vena cava. From the inferior vena cava, it bypasses the liver and passes through the ductus venosus. Then the next shunt is the foramen ovale. What is foramen ovale? Foramen ovale is a small foramen which is present and allows the blood to shunt from the right atrium into the left atrium. Normally, as you know, the blood has to go from the right atrium to the right ventricle and then into the pulmonary artery and then drain the left atrium. But here, because of this foramen, there is a hole in the septum. This shunt allows the blood from the right atrium to go directly into the left atrium through the foramen ovale. Then there is another shunt which is called as the ductus arteriosus, and this ductus arteriosus will shunt the blood from the pulmonary artery to the aorta. This is also a right to a left shunt, where you will find that the blood which is coming above from the superior vena cava passes through this ductus arteriosus and directly opens from the pulmonary artery, goes into the descending aorta. So it is also called as a right to a left shunt. So basically you will find that there are four shunts: one, the placenta; second, ductus venosus bypassing the liver; third, foramen ovale bypassing the right ventricle, so from the right to the left ventricle; and then we have got the ductus arteriosus, where blood from the superior vena cava goes directly from the pulmonary artery into the descending aorta. So here you can see that the diagram there, where you will find the shunts. Here you will find, this is the thing where you will have the umbilical artery, this is the umbilical vein passing through this and bypassing the liver and going into the things here. Here again you will find that here this is the lungs and this is the aorta, where you will find a connection. Foramen ovale is present here. Here from the right atrium it is going directly into the left atrium. This is the foramen ovale. So placenta is one shunt, this is the second shunt, this is the third shunt, and directly you will find that from the pulmonary artery, ductus arteriosus, blood going from the pulmonary artery directly into the aorta, descending thoracic aorta. So this is the pulmonary artery here, so blood going there directly from there into the ductus arteriosus. So these are the four shunts which are present in the fetal life, assisting the fetal circulation. Now, one of the characteristic feature of is the fetal hemoglobin. What is the advantage of the fetal hemoglobin? The fetal hemoglobin, the advantage is that the H hemoglobin F has a higher affinity for oxygen. It can carry 20 to 30% more of oxygen than the maternal hemoglobin. So the fetal hemoglobin concentration is around 50% more than in the mother. So the concentration of the hemoglobin in the blood is somewhere 50% more than that of the adult hemoglobin. And secondly, the fetal hemoglobin has got a higher affinity for oxygen, and hence it can carry a similar amount of hemoglobin, can carry more amount of oxygen when compared with the adults. So that is the feature, or that is the advantage of having a fetal hemoglobin, and this fetal hemoglobin is responsible for the double Bohr effect. I would advise, once the class is over, go and read what is double Bohr effect. So Bohr effect you would have seen in the respiratory cycle, where it helps in the transport of gases in hemoglobin. If you remember, it helps in the exchange of gases, where the concentration of the carbon dioxide becomes more, so there is a less affinity for oxygen and oxygen is released. This is a Bohr effect. So if you remember your respiratory cycle classes, there are two effects, Bohr effect and the Haldane effect in an adult hemoglobin. In fetus life, there is a phenomena which is known as double Bohr effect. All of you open your books and read what is this double Bohr effect. Now, what is regarding the carbon dioxide? The carbon dioxide builds up until it is slightly higher in the fetal umbilical arteries than in the intervillous spaces. So again, as I said, the transfer of oxygen is dependent upon the pressure gradient. So also the transfer of carbon dioxide depends upon the fetal gradient which is present there. So once the fetal body utilizes the oxygen, liberates the carbon dioxide, The carbon dioxide concentration in the umbilical arteries here is somewhere around 48 mmHg. That in the intervillous spaces is around 43 mmHg, and when it goes on across the placenta into the maternal circulation, the carbon dioxide concentration is somewhere around 40 mmHg. So there is a small pressure gradient where the gradient is forcing the carbon dioxide to go through diffusion from a higher concentration area to a lower concentration area. If you see here, the 48 mmHg is the higher gradient in the umbilical arteries, lower concentration, lower partial pressure of carbon dioxide in the intervillous space, it is 43. So this gradient is 48 to 43, and this helps in the transfer of carbon dioxide. From here, intervillous spaces, the maternal carbon dioxide PCO2 level is still more or less somewhere around 40 mmHg. So another gradient is there. So ultimately, the carbon dioxide diffuses from the arteries into the intervillous spaces, from intervillous spaces across the placenta into the maternal circulation. Secondly, the affinity for carbon dioxide is lower in fetus. This is where the double Bohr effects comes into play. So favoring transfer of carbon dioxide from the fetus to the mother. Nutrition is also similar by way of diffusion from the electrochemical gradients, where there is a higher concentration of the nutrients in the maternal circulation, lesser concentration of the nutrients in the fetal circulation, so there is a diffusion taking place. In addition to this, certain substances like antibodies, like hormones and LDL are through receptor mediated endocytosis from the mother into the fetal circulation. Then another important feature is the fetal renin angiotensin aldosterone system. Now here you should know that renin increases late in the gestation, and this increase in the renin concentration in the maternal circulation during the third trimester is because of increased renal sympathetic activity. It also is because there is a comparative reduction in the sodium and the blood volume, as a result of which there is a change in the renal perfusion pressure. We know that, as I had said in the first class, that there is, in the first slide I had showed you, that there is an increase in the body weight. Increase in the body weight partly is contributed by the fetal weight, placental weight, and increase in the plasma volume. When there is an increase in the plasma volume, there is an increase in the blood volume. Comparatively, there is a reduction in the sodium ion concentration. This changes the renal perfusion pressure. When the renal perfusion pressure is reduced, there is a less amount of renal circulation going, less filtration taking place. There is a less tubular filtrate load of sodium. This will stimulate the JGA apparatus to secrete renin. So late in the trimester, late in the gestation, you will find that there is a slight increase in the renin concentration. So this will cause the rise of the blood pressure in the third trimester of pregnancy. And other hormones, once the renin concentration is increased, you will find that there is an increase in the angiotensin, though directly it is not related to angiotensin, but this renin also helps to contribute to the increase in the concentration of angiotensin. So there is also simultaneously, there is a low ACE value, that is the angiotensin converting enzyme is also less. So once that is also reduced, there is an increased concentration of angiotensin. The aldosterone, which is secreted from the nephrons, has low concentration and is rapidly cleared. So three things will happen there. There is an increase in the renin concentration lately. There is aldosterone 2, which is direct and indirect effect. Direct effect is because of renin. Second effect is because of the low ACE enzyme present, and also aldosterone, which will be rapidly cleared and low in concentration. Now, how do you diagnose the fetal well-being? The diagnosis of the fetal well-being can be either doing a ultrasound scan, it can be abdominal ultrasound scan, or it can be a transvaginal ultrasound scan. It is a non-invasive procedure. Here it will be helpful in visualizing the vertebrae, the kidney, the bladder, the external the limbs, and by 12 weeks of gestation. The invasive technique is amniocentesis. When it is 14 to 16 weeks, the amniotic content, you introduce a needle into the amniotic cavity, and there is around 200 ml of amniotic fluid. You just remove around 20 to 20 ml and do it karyotyping and do a biochemical analysis study for the DNA for any abnormalities or genetic abnormalities present. The other method is chorionic villus sampling. It is a cytogenetic, that is, you study, take out the villus, and after 10 weeks of gestation, usually you take out that villus and send it for certain studying to a genetic center and biochemical testing. Fetal blood sampling, though it is rarely done, it can be done post delivery to understand fetal blood sampling, and also nowadays for the stem cell preservation. Now let us go, what are the changes in circulation at birth? Till now we have studied the fetal changes which happens during the intrauterine life. Now at birth, what are the various changes? A few changes are seen here. In the first of it, you will find that there is a loss of blood from the placenta. Now, the blood flow from the placenta suddenly comes to an abrupt halt, the systemic circulation takes place. This systemic circulation increases because there is 2 to 3 times increase in the vascular resistance. So what happens is that there is a suddenly, because of the cutting up of the blood supply and the placental circulation stops, there is an increase in the systemic vascular resistance, because of which now there is an decreased venous return to the right atrium compared to what was in the intrauterine life, and there is an increase in the aortic pressure. So two things are happening. The venous returns into the right atrium is reducing, whereas the systemic pressure is increasing. So on the pulmonary side, the pressure becomes a low pressure area, whereas on the systemic side, it becomes a high pressure area. Because of this, you will find that because of the difference in the pressure, once on the systemic side a high pressure, on the pulmonary side less pressure, there is a closure of the ductus venosus takes place. This closure of the ductus venosus takes place 3 to 7 days after birth. Now there is, as I said, pulmonary area becomes a low vascular area or a low pressure area. Why does it becomes a low pressure area? The pulmonary vascular resistance decreases because there is now a lung expansion taking place. Initially the lungs were already collapsed and they were offering very high resistance, but now after the child is born, the elasticity is increased. There is an expansion of the lungs taking place. Because the lungs are expanding now, the resistance which is offered there, the alveolar resistance and the resistance on the pulmonary side gets reduced. And in addition to this, there is a vasodilatation taking place because of the release of many vasodilators. The vasodilators which are mostly released are the prostaglandin 12, bradykinin, and most important is the nitric oxide. Once the sufficient quantities of this nitric oxide is released, there is a sudden vasodilatation. When there is a vasodilatation on the pulmonary side, you will find that the pulmonary vascular resistance is reduced. When the pulmonary vascular resistance is reduced, it becomes a low pressure area, and this decreases the pulmonary artery pressure, and the right atrial pressure also falls. So what was very high in the intrauterine life, where the pulmonary artery pressure was high, the right atrial pressure was high, has now suddenly fallen down. The foramen ovale also closes, the foramens also close. Right atrial pressure, as I said, the right atrial pressure is reduced, there is a high in the left atrial pressure. This is because of the resistance. The pulmonary resistance reduces, the systemic resistance increases. Now because of this high pressure and low pressure, the valve on the left side of the atrium is pushed close. So as a result of which, you will find that there is a closure of the foramen ovale takes place. Similarly, the ductus arteriosus also closes. Here there is a high aortic pressure and a low pulmonary artery pressure. Now this also will cause the pressure gradient will also cause an increase in the flow of the blood. Because of this increase in the flow of the blood, the oxygen supply is increasing, as a result of which the smooth muscle wall also constricts. So now there is more oxygen supply there. Because of the more oxygen supply, the smooth muscle which is present in the vessel wall will also contract, and this contraction will cause vasoconstriction and the blood flow stops. So this also causes the closure of the ductus arteriosus. Now how do you see when a neonate? When a neonate is born, it is typically covered in vernix, white greasy substance or cheesy substance which is called as a vernix, and the child or the neonate when it is born should be typically pinkish. The cardiac output is high, somewhere it's around, the cardiac output is around, the blood volume itself is 500 ml, the respiratory rate is high, the heart rate is high. The heart rates, as I said initially, in the newborns are somewhere around 120 to 140 per minute. The respiratory rate is around 40 per minute. If Remember in the class, in the first class of the respiratory cycle, I had told you that you should remember these rates, you should remember the cardiac output, you should remember the heart rate, you should remember the stroke volume. There you will see that all these values are very high. The blood pressure initially is around 50 by 30, that is 50 systolic, 30 diastolic. After a few days, it increases to 80 systolic, 50 diastolic, and after 6 months, the blood pressure comes back to around 90 systolic and 60 diastolic. It is a normal sinus rhythm. The respiratory rate is somewhere around 35 to 40 per minute. Initially, for a short period, you will find that during the REM sleep, where the child are having dream, there will be sudden increase or spurt in the respiratory rate. Here it is the pressure volume curves for the lungs in the neonate. Here you will find, see this, here it is the pressure in the first breath, here it is the volume. See the pressure, as the pressure is becoming more and more negative, intrapleural pressure is falling from 0 mmHg to minus 40 mmHg. You will find that the volume of the lungs is increasing. This is the first breath which is taking place. So here there is initially no volume, it was all filled with water. There is a sudden emptying taking place at plus 40 mmHg. 0 mmHg is the pressure now. When the child breathes the first time, there is an expansion of lung taking place, the intrapleural pressure falls. It goes around to minus 40 mmHg. That is the first cry which happens, and this first cry becomes very important because it indicates the expansion of the lungs, and the child has started breathing on its own. See here, the pressure has to fall down to minus 40 mmHg, and there the volume of the lung is 0. So at birth, for the first child, it is 0. For the first time, it is 0. Then when the child breathes in air, the lung volume increases, the thoracic cavity increases, air enters, and the respiratory cycle starts. So now the lungs are filled with around 20 to 30 ml of oxygen there. See, as the second breath takes place, you will find that this curve is now going, the pressure has to fall somewhere around minus 20 to minus 40, but there is always some amount of air present in the lungs, say somewhere around 10 to 15 ml. Now with the breath, you will find that it is going to around 30 ml per minute, 30 ml of oxygen is present. Now with little change in the pressure, after 1 hour of taking a normal breathing, with a little change in the pressure, the volume of the lungs increases. So this is how, with less and less effort, the child begins to breathe. If this doesn't happen, or if there is a difficulty in the lung expansion, this exchange of gases will not take place, and the child is leading into a hyaline membrane disease, or it is known as respiratory distress syndrome. Now, what are the changes which are taking place? Metabolic activity. The metabolic activity in a child, you will see, is much more higher than compared to adult. Mostly, if you see most of the parameters, it is around 1.5 times to 2 times more than the adult in a neonate. So metabolism, twice that happens on the adult, the metabolic rate. The acid production is also twice the normal that happens in an adult. The concentration of the kidney is only 1.5 times osmoles that of the plasma. The liver initially has a deficiency in forming plasma proteins. It is slow in producing plasma proteins, gluconeogenesis, and there is a deficiency of clotting factors. Especially this, there is a deficiency because the liver is not fully functional. You will find that there is a deficiency of vitamin K. If the vitamin K deficiency is not corrected initially, it will lead to decreased clotting factors and a bleeding disorder. Hence, one of the thing which is being given in a neonate is you inject vitamin K. Once you get vitamin K, you stimulate the production of in the liver. The production of various clotting factors happens so that the bleeding disorder is prevented. And in a newborn, you will find that the hemoglobin F is the fetal hemoglobin. 75 to 85% of the hemoglobin is of the hemoglobin fetal type, because of which there is a high erythropoiesis. Gradually, over the next 6 months, you will find that the fetal hemoglobin F is replaced by means of adult hemoglobin. See this, initially because there is a high RBC count, you will find that there is a hemolysis taking place in birth. So as the age progresses, you will find 12 weeks, 10 weeks, you will find that because of the high RBC count, somewhere around 5 million per cubic mm, the bilirubin, there will be more breakdown of RBCs, and initially you will find that there is a high serum bilirubin levels, which is known as a physiological jaundice. But as age advances, the RBC count remains stable, the lysis of the RBC also comes down, the body is able to metabolize the bilirubin, and the bilirubin level comes back to normal. So initially there is a jaundice which we call as hyperbilirubinemia. This is a physiological bilirubinemia which happens, and it happens at the end of the first or in the second week of birth. Now, what are the nutritional needs of a neonat? Initially, you will find that the child needs to be given calcium because it's a growing child. You have to take care of certain supplements, and the supplements are to be in the form of vitamins. Vitamin C is not stored in the child, so they need supplements. Iron supplements is to be given so that it builds up, and in the liver it is stored for 4 to 6 months for sufficient or an adequate bone growth. Calcium supplements has to be given. Initially there is no immune system is not well developed, therefore it is the mother's antibodies or the IgG mothers which is coming from the mother during pregnancy or through the breast milk. You will find that antibodies, IgA antibodies, are transferred from the mother to the child in high concentration, which gives a immunoprotection to the child from various diseases. By 3 months of age, the IgA antibody begins to produce within the child, and initially you will also have to take place of hypoglycemia. Hypoglycemia is one of the risk factors in neonates because there is a low glycogen stores, and because of this low glycogen storage, there is a chance that the glucose levels may fall. So hypoglycemia is one of the risk factors which you have to look again and again in the newborns, and especially in premature neonates. The incidence of hypoglycemia is high. That is why constant feeding, every hourly feeding or every once in 2 hours, if the child is being fed on the breast milk, it will take care of the hypoglycemia. Now, a special case where in a child of diabetic mother is having a high glucose level. This high glucose level crosses the placenta, the risk being there then once the high glucose concentration is passing through the placenta into the newborn, there is a risk of transient hypoglycemia 1 to 4 hours after birth. The plasma insulin normalizes 12 to 24 hours afterwards. Therefore, for a child of a diabetic mother, the risk factor for a hypoglycemia is still more higher, like something like a neonate. The child born is large for gestational age. That means large for gestational age means the child normally should be somewhere around 3.5 kgs, whereas of a diabetic mother, the weight of the child is somewhat large for that particular gestational age, and they may be born with 4.5 kgs child. It's an anabolic state where proteins, lipids and glycogen synthesis takes place. One of the other feature of a diabetic mother is that if a mother is having a diabetic vascular disease, there is a high incidence of intrauterine growth retardation during the pregnancy in the neonate. Then after delivery, they can have a high incidence of respiratory distress syndrome where the lungs expansion is not taking place, adequate amount of surfactant is not being synthesized, leading to RDS, infant respiratory distress syndrome, or it is also known as hyaline membrane disease. The other features which are seen in the child of a diabetic mother are they are having low concentration of calcium, low concentration of magnesium. Polycythemia will be there initially, but because of this high polycythemia, the RBC count is increased. After delivery, when the child is born, there is an increased lysis of the RBCs taking place because the RBC count is high. So more lysis of RBCs takes place. When more lysis of RBCs takes place, there is a high hyperbilirubinemia, and this hyperbilirubinemia may persist for a little longer time. And in children of diabetic mother, there is an increased risk of congenital defects and brain damage. The chances of a child of a diabetic mother becoming diabetic by the age of 20 is supposed to be the 7 times higher than with a non-diabetic mother. Chances of a child of a diabetic father becoming diabetic is 20%. So these are just probability statistical analysis where it is seen that if the mother is diabetic, the child by the age of 20, there is a risk of 7 times than with a mother who is non-diabetic develops by the age of 20 years. Whereas if the father of the child is a diabetic, there is only a 20% probability. Lastly, there are certain growth milestones you have to remember. Now, one thing you remember is once the child is born, you have to monitor the milestones. The milestones are something like smiling of the child, clawing of the child, crawling of the child, sitting of the child, standing of the child, walking and walking alone. So remember broadly, by the end of the 1 month, the child neonate, when he is 1 month old, he should be able to smile. Broadly remember, 1 month the child should begin to smile. By the third month, the child should be able to move the hands and the fingers and should show certain grimace on the face. By 6 months, the child should be able to sit alone. By the end of 11 months of age, he should be able to stand up alone. By the end of 11th month, he should be able to walk with support, and by the end of 1 year, 12 months, the child should be able to walk all alone. So remember these factors. 1 month, it should child to smile. By 3 months, hand movements, finger movements should be there. By 6 months, the child should be able to sit alone. By 10 months, the child should be able to stand straight alone without support. By 11 months, he should be able to walk with support. By the end of 12 months, they should be able to walk without any support. So just look for these milestones. If you find that during your visits when the mother is bringing the child and you are finding that the milestones are getting delayed, you should investigate the cause for the delay in the milestones. Thank you. All of you have a nice day. We'll have another next class on Wednesday where we'll discuss about the sports physiology.